Morning, everybody, and honoured to present to you in Bankstown. I was last on your base in 2019. I came over for SMAC, and I gave a presentation then too, actually. So it'd be great to know if there's any of you that were there then that are listening to me again. But thank you for having me and for the invitation. The reason I'm doing this is I don't work at London HEMS, not yet. I'm working there this summer, but I have read the paper that we're going to talk about, which is this one. It's open access in JAMA surgery, and I have spoken to several of the authors and discussed the paper with them. And I have written a review of it, which is published on St Emlyn's blog. And that's how Natalie sort of picked me up to sort of come and speak to you, not to sort of do a journal club and dissect the critical appraisal of the paper, but to present the paper to you and discuss my sort of clinical interpretation of what I think this paper might tell us. And I don't particularly want to focus just on resuscitative thoracotomy. I think it tells us things more broadly about traumatic cardiac arrest or traumatic circulatory arrest than just thoracotomy. So that's what we're going to do. I'll present the data to you briefly, and I'll pick out the key bits, and then we'll discuss sort of what I think the key implications are of this on our clinical practice for managing circulatory arrest, and show you what I think my sort of lessons learned are from it. I think that'll take me half an hour or so. The slot's an hour. So after that, we've got time to discuss. And I think it's well worth picking this apart, seeing what you think of it, comparing it to your Sydney HEMS SOP for TCA. You're very welcome to ask me questions, but I'm no particular expert. I'm just a sounding board with great interest in this subject. So here's what here's the contents of the paper. It's a 20 years retrospective trial with a lot of patients that were attended. 45,000, 3 and a bit thousand were in TCA, and 601 of those had pre-hospital resuscitative thoracotomy delivered by London's air ambulance team. That's the first thing that's interesting about this. You've got to be slightly careful about overgeneralizing. So 3 and a bit thousand TCAs, 600 of which got thoracotomy. And I'm perhaps guilty of generalizing this entire article to all TCA. This is actually only patients that were in TCA and had a thoracotomy. 600 of them, though, so a big case series internationally. 88% of them had penetrating trauma. Now, that's interesting too. It is almost unique, probably. I'm struggling to think of another very urban city with that level of penetrating violent crime that has a pre-hospital service like yours or ours. Where I'm in EAAA, we're a predominantly rural area, and we don't have that level of violent trauma. And the sort of cities in America that have that level of violent trauma don't have a pre-hospital service like yours or like London. So it's a fairly unusual data set. And there you go at the bottom, 5% survival to discharge, 30 of them out of 601, which is pretty bad, but no worse than any other type of out-of-hospital cardiac arrest. And we're going to zoom in a bit more on who those survivors are and what the positive predictive factors are for survival. As we have that discussion, there are 3 key things to bear in mind, and they are these 3. Represented by the knife, which represents mechanism, the clock, which represents time, and the heart, which represents the heart. The first thing we'll talk about is mechanism, and we usually subdivide, or what's that word where you divide things in? Never mind. TCA by the mechanism, right? Because it's quick to do, it's instant. We know before we even get there whether it's a penetrating TCA or a blunt one. And what we really need to know is that just an easy subdivision, or is it a clinically important one? And probably the way to answer that is to look at whether there's a difference in the survival of patients with penetrating trauma versus blunt trauma. There is, but if you look at patients with penetrating trauma that's caused cardiac tamponade versus patients with blunt trauma that's caused cardiac tamponade, there is no difference in their survival whatsoever. The survival is equal from tamponade, regardless of whether they've had tamponade or exsanguination. So they're probably much more interesting things to look at. And here are some sort of very key graphs from this publication, which show the survival from patients who had cardiac tamponade versus the survival of patients who had exsanguinated. There's 2 things to pick out from this. The first is that the decline in survival over time is huge. Look at the tamponade graph. If you intervene immediately, 55% survival. If you intervene 5 minutes later, 25%. So there's a lot of percentage of survival lost in a very short period of time because that graph is so steep. And then look at the one on the right, exsanguination. It follows the same sort of trajectory, but it's a pretty dismal curve with very, very poor survival. Even if the intervention is essentially immediate, the survivability of that is less than 5%. So let's put some more numbers on these two groups. Rather than penetrating versus blunt, let's put some numbers on tamponade versus exsanguination pathophysiology. And here they are. What's a bit sad is that exsanguination was much, much more common. 70% of these cases had exsanguinated. 17.6% had tamponade, as you can see. Now, that doesn't reach 100, and that's because there were a proportion of patients that had both tamponade and exsanguination together. That in itself is kind of interesting, actually. If you think about how that happens, it's a bit difficult to get your head around. I think, no one can tell me for sure, but I've seen one of these myself who died, as did all of the ones in the London HEMS cohort that had tamponade and exsanguination. They all died. I think it's where you have high pressure hemorrhage that is causing exsanguination from the heart, so from a ventricular injury or coronary artery. And then as that patient deteriorates, that becomes low pressure hemorrhage, which then is contained by the defect in the pericardium. It's no longer high pressure enough to bleed through the pericardium. And then tamponade is latterly caused at the point of circulatory arrest. So I think they're exsanguination patients really that end up with a sort of perimortem tamponade. So here we are, very common to have exsanguination, and look at the difference in survival. Overall, 21% survival from tamponade, 1.6%, terrible, terrible survival from thoracotomy for exsanguination, less than 2%. Bear that in mind, we'll come back to that later. I think it's more interesting, therefore, isn't it, with 21% survival to focus on the tamponade patients. So let's do that. Here's the tamponade graph on its own. And here is the comparison of penetrating trauma tamponade and blunt trauma tamponade. It's the same, no clinically significant difference. The incidence of blunt trauma tamponade was rare. There's only 4 patients, so one of those 4 survived in this group. But there's another publication done by another neighbouring service, UK Geography. It's us at EAAA, then the next one down is Essex and Herts, and the next one down is London. Essex and Herts have published an article about prehospital thoracotomy. Very poor outcomes for them, all died. And they had about 15% of their blunt traumas had tamponade. So blunt trauma tamponade is a real thing. And this data set shows that if you do a thoracotomy on them, the survival is as good as the survival from penetrating trauma tamponade. And that is definitely food for thought for all of us, because most of our SOPs exclude or very nearly completely exclude thoracotomy as a treatment for blunt trauma TCA. Let's think more about that then. The challenge here is, how do we reliably and rapidly identify cardiac tamponade to select these patients out as the ones who are candidates for intervention versus stop performing multiple futile thoracotomies on patients that have exsanguinated? And I think there are probably 2 opportunities to do that. The first is something to do with the mechanism. And if you look at this cohort of London HEMS' patients, the only patients with penetrating trauma that had tamponade had a penetrating injury to the chest or to the epigastrium, nowhere else. No back, no abdomen, no neck, no axilla, no groin, no thigh, no nothing. No penetrating trauma anywhere else caused tamponade ever in that data set. If we zoom in a bit more on that statistic, because it is interesting, of the patients that had thoracic or epigastric stabs, or gunshots, but most of these were stabs, 60% of them had still exsanguinated. So the takeaway is thoracic or epigastric stab, 40% chance of that being tamponade. My personal feeling is, given the acuity of the situation and how quickly survival deteriorates, that 40% chance is probably enough to justify that if you think it's a candidate patient, cardiac tamponade is likely enough. And therefore, I think I would intervene with thoracotomy. If they don't have a thoracic or epigastric stab, it becomes a bit more difficult. Ultrasound might be the answer, and there's a picture of a probe there. I am cautious of that. And I mean, I'll share with you some hard-learned personal experience, which is I have misinterpreted a prehospital ultrasound of a patient with an epigastric stab that had cardiac tamponade. And I misinterpreted it because I was rushing, I was adrenalized, it was late at night, the scene was challenging, and I had a quick look beware the quick look. And there was partially clotted pericardial blood that had exactly the same echo density as the ventricle. I was looking for a big black rim and there was no black rim there. So I learned a hard lesson there. I very nearly said no tamponade, no thoracotomy. And then I scanned her again and realized there was partially clotted blood with right ventricular collapse. So ultrasound, be really careful. Be careful of taking too long and the survival curve slipping away from you, and be careful of misinterpreting a scan in a rush. It's easily done. Believe it from me, as a lesson hard learned. So lesson 1, identify potential tamponade early. And I think those are the best 2 ways of doing it: thoracic or epigastric penetrating trauma, or you've seen it on ultrasound. And lesson learned 2, non-chest or epigastric penetrating trauma patients had all exsanguinated. So if they don't have that mechanism, or they have a penetrating mechanism elsewhere, exsanguination is the pathophysiology, and that will start to guide your decision making about thoracotomy candidacy. So let's look at the positive factors for survival. These were them: the duration of TCA, you've seen that on the graph, the cardiac rhythm, and then all of those 3 things at the bottom: no CPR, no internal cardiac massage, and no adrenaline, were all positively predictive for survival. We'll come back to those last 3. Let's look at rhythm quickly. This is super helpful, and it's a really great lesson learned that I think is something that can be applied to our SOPs very, very quickly. And the lesson is that the adequacy or intensity of electrical activity correlated extremely well in a perfectly linear fashion with the duration of TCA and hence survivability. If you look at it in this fashion, sinus rhythm deteriorates to bradycardia, deteriorates to a broad bradyagonal thing, deteriorates to asystole, and it did it like this. The green line represents tamponade. At 15 minutes, they were almost all asystolic. They deteriorated in a linear fashion of electrical activity. The nice thing is that the exsanguination patients did pretty much exactly the same thing, just with a steeper line. And if we look back at our survival curves and overlay those electrical activities, you can see that the presence or absence of electrical activity is giving us a very reliable indicator, much more reliable than trying to guess the time or trying to estimate things based on end-tidal CO2. It's giving us a really reliable indicator as to survivability. If someone has coordinated electrical activity, whether they have tamponade or exsanguination, they have the best possible survivability. If someone has asystole, there's no surprise, they have the worst possible survivability. And what's quite nice, you can see by the bars that the pattern is the same with tamponade or exsanguination. Just with exsanguination, the bars are very low and very compressed because the survival overall is so poor. So using electrical activity as an idea of survivability is probably very helpful. And I'll show you at the end how London's Air Ambulance have already issued an interim update to their SOP to incorporate that into decision making. Going back to our list of positive factors for survival from tamponade, we've sort of covered the first 2, duration and rhythm. And I think all of these factors are really showing us indicators towards time since arrest. If someone didn't have CPR, it's probably because the critical care team witnessed the cardiac arrest. If someone didn't have internal cardiac massage, it's probably because the heart hadn't stopped. And the same with adrenaline. So all of these things are probably just telling us how far the patient is on that spectrum of decline or on that curve. These 3 in particular, no external chest compression, no internal cardiac massage, no adrenaline, are probably telling us that these patients are ones that have been intervened on before the heart has stopped. And that is telling us that early intervention for tamponade is absolutely essential. And here's a list of things. This is the opinion of me, not written in a publication. Here is a list of things that cost time. Putting a tube in the patient, particularly when it's only the critical care team that can do that, will take a couple of minutes. And think back to that graph and how much survival is lost in that couple of minutes. Sort of tens of % of survival is lost in the time it takes to intubate. The HOT approach thoracostomy in a patient that clearly has tamponade is probably a waste of time and should just be considered to be the start of the thoracotomy rather than put the thoracostomy, paused and think. Gaining access, giving volume, that needs to be concurrent and done by probably our ambulance service colleagues if it's just a pre-hospital critical care team that can deliver the thoracotomy. And this is a controversial one, extrication. The traditional teaching for prehospital thoracotomy, certainly here, and I'm sure it's very similar for yourselves in Sydney, is you need 360 access to do it. And if they're in arrest in a divey alleyway or a caravan or whatever, you need to pull them out. Or if they're in an ambulance, you need to pull them off the ambulance to do the thoracotomy out the back of it. That was certainly London HEMS' teaching for many, many years. It's not now. If you're completely honest with yourself, how long does it take to get a scoop under someone and get them out of a caravan or get them off an ambulance? A lot of ours in the UK have a hydraulic tail lift that comes down at like this speed. And just to deploy the tail lift takes 2 minutes. So 2 minutes to deploy the tail lift, a minute to unlock the stretcher and get it off, another minute to get the stretcher to the ground level. That's 4 minutes. So if you think back to that graph, how much survival is lost in 4 minutes, getting them off the ambulance to make your procedure easier is potentially a difference between the patient surviving or not. Also, getting them off the ambulance or out of wherever they are to make the procedure easier is potentially the difference between neurologically intact survival or not. And this is also something that I and others have incorporated into our practice very early, which is tamponade thoracotomy is not something that can wait for us to optimize the situation. We have to adapt to the situation rather than adapt the situation to us. And since learning this, I've done one thoracotomy in a caravan that was difficult but achievable, and one in an ambulance, in the back of an ambulance, that was difficult but achievable, and also had the advantages of keeping us out of the public gaze, keeping us out of the cold, out of the dark, out of the rain, and keeping us from having to load the patient again with the open chest, attached to the defib and attached to all our infusions and attached to all of that stuff. So although doing the procedure is slightly more challenging, it's achievable with practice, and the subsequent steps of doing it on the ambulance are much easier. And the final one in bold at the bottom is, are we right or wrong to wait? This is cat going among pigeons, warning. Are we right or wrong to wait for the patient to actually have a cardiac arrest? Oh gosh. Let's look at the paper again. Here we go. Here are the adjusted odds ratios of survival. And at the bottom there in the red box is a 0.2 adjusted odds ratio of survival if the patient needed internal cardiac massage. So, and that's highly significant, less than 0.01 p-value. So what that is telling us is if the patient's heart had stopped, i.e. they were in cardiac arrest, they had a 80% lower chance of surviving than if the heart was still beating at the time of thoracotomy. Ooh, this is food for thought, isn't it? Because we're always taught that thoracotomy is a treatment for traumatic cardiac arrest. And in this case series, the best survivors are the ones where the heart was still moving. So let's think about that a bit more and see if I can make that a bit less spooky. As you heard, I do a little bit of cardiothoracic intensive care, and cardiac tamponade is something that we see not infrequently after cardiac surgery. Think of a pulmonary artery bypass graft that's bleeding and the drain is blocked or whatever. And we don't wait for them to arrest before we call the surgeon and take them back to the theatre. If they do arrest, we reopen them on the ICU. If they're very unstable from tamponade, we reopen them on the ICU. We'll do that ourselves. We won't wait for the cardiac surgeon. Ideally, we diagnose tamponade, we get the cardiac surgeon, and we send them to the theatre while the heart's still beating. We reopen them, decompress the tamponade, and sort the bleeder out. So I don't know, other than perhaps ethics, simplicity, decision making, I don't know of a sort of pathophysiological reason why the pre-hospital thoracotomy for tamponade has only ever been an intervention for cardiac arrest, and why we haven't yet been empowered to intervene on someone that we know or highly suspect to have thoracotomy, where decompression of to have tamponade, where decompression of that tamponade is inevitable. I have done this, and I did it before I knew this information. So there was a lady who had a epigastric stab. She was peri-arrest, agitated, electrical activity, decreasing level of consciousness, unrecordable blood pressure, and obvious tamponade on ultrasound. And our decision maker, and very, very long way from any receiving facility that could cope, like 45 minutes away by road with no air conveyance option. So decision making was hard, and we sort of got our heads together and decided that we were going to prepare for thoracotomy, give the patient an RSI, intubate them, and then do a thoracotomy. And we did the thoracotomy. The heart was still beating. There was a bleeder from the RV. We closed that with staples, gave her a lot of blood transfusion, took her in. She survived, GCS 15 survivor. And I thought, oh my goodness, have I just done a sort of semi-elective resuscitative thoracotomy of a procedure that's meant to be for TCA? And are people going to hang me out to dry? And the answer was no. The answer was, this is how you generate the best survival, is decompressed tamponade before the heart has beat itself to death. So some massive food for thought there. Look at that adjusted odds ratio and think, is this an intervention for when the heart has stopped, or is the opportunity to intervene for these tamponade patients before the heart has stopped? That's 3 rules on tamponade. We'll come back to the rules at the end, the learning points. Let's look at the exsanguination patients again. So survival was dismal, and even more dismal beyond 5 minutes, and even more dismal without electrical activity. There was none. More than 5 minutes, no electrical activity, they all died. And bear in mind, the vast majority of the patients in this data set, 70% of them, had exsanguination. So this is significant data. The positive predictive factors for survival were these 3. All of them had penetrating trauma exsanguination. Almost all of them had been in TCA for less than a minute, and it had been witnessed by the Hames team. And all of them had sinus rhythm at the point of a thoracotomy. The penetrating thing's interesting. And I think, again, this isn't written in the paper. This is just thoughts from me and discussing it with lots of people who are interested in it like I am. I think that the positive predictive factor of survivability for penetrating trauma exsanguination TCA is identifiable bleeding points. If you have a penetrating injury, you're like a single penetrating injury, you're likely to have a single bleeding point, which is controllable. If you have multiple bilateral stabs, the survivability was substantially worse, like less than 25% of that with an isolated injury. It's all in the supplementary data. There's loads of supplementary data. And if you have blunt trauma, then usually you have either an uncontrollable exsanguinating injury, like a massive liver laceration that is not controllable by someone like me, or multiple bleeding points from soft tissue beds of usually solid organs, like bleeding from liver, spleen, kidney, for example, that is not controllable in our setting. So I think that's why penetrating injury was positively predictive of survival for exsanguination, and the others, they go without saying, right? Zane Perkins uses the phrase for these exsanguinating patients that once the heart has stopped, it's beat itself to death and nothing we can do will get it going again. And that certainly seems to be the case. So if we think back right to the start, where I showed you that the survival from exsanguination TCA was 1.8%, less than 2%, it's definitely clear that thoracotomy for exsanguination TCA has to have some of these, or even all of these ideally, positive factors to be survivable. Or do I put the cat among the pigeons a little bit more and say resuscitative thoracotomy is not a helpful treatment for exsanguination TCA? Don't know. I mean, if someone said to me, Hutch, the chance of survival is 2%, but it's really disfiguring and distressing to everyone around, do you want it? I'd probably say not really. Like if someone offered me chemotherapy and the chance of survival was 2%, I'd say no. So I don't know. That's a difficult question. It's almost as kind of ethical as is adrenaline a helpful treatment for out-of-hospital medical cardiac arrest in the context of the Paramedic 2 trial. It's difficult. So if RT doesn't help exsanguination TCA, what does? And it's probably these 2 things, transfusion or volume resuscitation, plus minus aortic occlusion. So I wanted, if I may, to dwell for a few minutes on the physiology of aortic occlusion. I'm a bit of a nerd about this, and you heard from Jenkin at the start that I'm part of the team delivering the ERICA arrest trial. So that trial uses REBOA in medical cardiac arrest to augment coronary perfusion, and I thought this would be a good opportunity to share some interesting physiology with you. So there's a REBOA balloon in an aorta, and I'm using REBOA as an example, but with caution, and I want to just contextualize that I use aortic occlusion in the broadest possible way, either as a REBOA catheter or as a hand on the aorta, because the physiology is the same, whether we're occluding internally or externally. So occlusion achieves hemorrhage control, right? That's blood coming down from the top, hitting the balloon and not going any further, we think. But having done in animal labs some laparotomy with aortic occlusion in place, there is quite substantial collateral in the anterior chest wall, the anterior abdominal wall, and actually still quite a bit of bleeding takes place below the occluded aorta, whether that's REBOA or a hand on it. So actually, although it provides some hemorrhage control, occluding the descending thoracic aorta doesn't provide ultimate zero bleeding whatsoever hemorrhage control in the way that many people thought it might, me included. So it's worth looking a bit more at the physiology to see how aortic occlusion helps these exsanguinating patients. And I mean aortic occlusion, not REBOA, because most of these patients, or in fact, in this data set, all of the ones that had a thoracotomy for exsanguination, all of them had aortic occlusion with the hand. Here's some blood pressures: 63 over 40, 76 over 23, 180 over 120. And I sometimes ask people to say, you know, which of these is worst, and sort of less experienced people among the audience usually pick up the systolic of 63. If you put the maps on it, maybe indicates that that middle one is worse, 76 over 23, because of diastolic hypotension, making a big contribution to that map. So I think that the one on the left is just a normal low blood pressure. The one on the middle is as a result of the loss of the arterial pressure reservoir, and I'll explain what that is in a minute. And the one on the right is artifact from NIBP, because at extremes of hypertension or extremes of tachycardia, NIBP just kind of takes a guess because the oscillometric technique is not able to measure. In fact, my most recent thoracotomy, the trigger for doing it was a hypotensive, deteriorating patient with multiple bilateral stabs with severe tachycardia, unconsciousness, massive pneumothorax, detected on thoracostomy, but still had cardiac output, and then deteriorated with low CO2. And the final piece of the jigsaw was that we had a 220 over 180 NIBP. And I said, oh, well, that represents loss of cardiac output, and we'll proceed. And he had arrested. Let's dwell on this middle one, loss of the arterial pressure reservoir. So some physiology coming up. The first bit of understanding is how does large arterial compliance contribute to diastole. So imagine that this box is an aorta, and we're going to fill that aorta with blood. The aorta will distend, and then the elasticity in that aorta will squeeze back, and that squeeze back is what generates diastole. So we need to distend arteries in order to generate that elastance, in order to promote diastolic pressure. So let's look at a pathophysiological example now, which is low stroke volume. Very little stroke volume, blood only half filled the vessel. It didn't distend it at all. And so the elastance was lost. Well, the elastance wasn't lost, but there was no distension because the stroke volume was low. And as a result, the arterial pressure reservoir is no longer having its effect. So that's low stroke volume. And that is how low stroke volume contributes to diastolic hypotension. The other way of getting this diastolic hypotension in trauma is where there's a big hole in a big vessel. And even if the stroke volume is good, you fill it, blood spills out from the vessel rather than distending it. And without the distension, you don't get the diastolic pressure, you get diastolic hypotension, and that is caused by loss of elastance. So there are two ways to lose your arterial pressure reservoir: loss of elastance because of a big arterial hole, or low stroke volume because of volume loss and exsanguination. Both of those things remove the cause diastolic hypotension, and NIBP won't detect this. You need an invasive arterial line to detect it, and that is because the oscillometric technique doesn't measure systolic and diastolic. It measures MAP and then approximates systolic and diastolic based on some clever maths. So this is only detectable with an arterial line, and that's the pathophysiology behind diastolic hypotension in trauma: low stroke volume or low elastance. The so what is you get diastolic hypotension, and the so what of that is that coronary perfusion equals diastolic pressure minus right atrial pressure. Assume that your right atrial pressure is fixed to make it easy maths. The lower your diastolic pressure is, the lower your coronary perfusion is. And we are learning that we need a coronary perfusion pressure of at least sort of 15 in order to adequately perfuse the myocardium to prevent or undo cardiac arrest. So think back to our options for treating exsanguination. They were transfusion, and that restores stroke volume to promote coronary perfusion, or aortic occlusion, if the problem is a big hole in a big artery causing loss of elastance. That's probably how aortic occlusion is beneficial in these exsanguinated patients. Is it relatively restores the stroke volume because you are only perfusing a small bit of the aorta, just the arch, and it restores elastance if there's a big hole in a big vessel. And by big vessel, I mean descending aorta, renal artery, mesenteric, or common iliac, something like that. So those things put together restore coronary perfusion, and I think the answer to exsanguination is restore coronary perfusion to prevent circulatory arrest rather than allow it to happen. And if you want to know more about that, the paper that contains much more information on this stuff is another one by London Hems, and that is their use of zone 1 partial REBOA for exsanguination, where there are, I think, 8. There are 8 patients demonstrating this physiology. That's the interesting physiology of the exsanguination cases. So that's it. That's all I wanted to share with you in terms of the paper and in terms of sort of my lessons learned. So we'll sum those up and talk about this sort of clinical so what's. So the first 3 lessons learned were for tamponade. Identify it really early. Non-chest or epigastric penetrating trauma seems to only ever cause exsanguination in this data set, and early intervention is essential for survivability. Think back to that little list of things that were negative for survival, and that list of, as in CPR, internal cardiac massage, adrenaline, and that list of things that I think needs to be deprioritized in someone that is highly likely or has been detected to have tamponade, including extricating them. And the next was for the next 3 lessons learned were for exsanguination. RT for exsanguination needs positive factors, or survival was less than 2%. Is RT not a helpful treatment for exsanguination TCA? And the final one, the bit of physiology we did, is restore coronary perfusion to prevent arrest. So I'm going to finish with 2 things. The first is, how have London's Air Ambulance updated their SOP? And the second is some sort of challenges for us all, and the so what's of what can we do with this information. So this is the end of the interim update to the SOP. And it says green is do a thoracotomy, red is don't do a thoracotomy. If a patient has certain or highly likely tamponade, highly likely as in they have chest or epigastric penetrating injury, or highly likely as in you've probably seen it on ultrasound, and they have electrical activity, go on ahead. If they have no coordinated electrical activity, but it's less than 15 minutes since arrest, probably go ahead. If they've exsanguinated and they've got electrical activity, go ahead. If they've exsanguinated with no electrical activity, that seems to be unsurvivable. The heart has beat itself to death, and thoracotomy, indeed, thoracotomy and ongoing resuscitation are probably both not indicated. So that's how London Hems have updated their SOP. And the next one is my last slide, and it is sort of the challenges for us all is to what do we do with this information now? Can we rapidly and reliably identify the pathophysiology, i.e. can we rapidly and reliably distinguish between tamponade and exsanguination? And it's important to emphasize at this point that this was a retrospective study, and the diagnosis was made after the decision to do the thoracotomy, not before. And I think one of the say what's is we need to be learning how can we decide to do a thoracotomy or not based on knowing the diagnosis rather than based on an assumption on the mechanism, which this data proves to be wrong. Can we learn to relieve tamponade prior to the patient arresting? Well, we can, and I told you about that case where I've done exactly that. And I know of colleagues that have done the same thing, but it's a bit of a step outside of the usual established norms of putting the patient to sleep to do a thoracotomy. And I think that will need to be reviewed by organisations and their governance at a senior level, and SOPs adapted in accordance to whether that organisation sees fit to adapt their SOPs or not. The survivability would certainly suggest that organisations should think about how can we do that in a safe and reliable way, a responsible way. Can we rescue the heart prior to exsanguination arrest? Because the survivability, once the heart has stopped, 1.8%. It's dire. And the focus has to be on arresting hemorrhage, promotion of coronary perfusion early, and preventing cardiac arrest in those two ways. And there's something in there about volume resuscitation, and there's something in there about aortic occlusion, whether that is via a thoracotomy, whether that's clamshell or left lateral. There are some services in the UK that have evolved to offer the left lateral thoracotomy purely to occlude the aorta in exsanguination cardiac arrest. No survivors yet, mind. No surprise there. Or whether that's with aortic occlusion via a balloon. And the final one, this is a challenge for many of us, and it goes against much of the traditional teaching about RT, is can we learn to adapt to the situation in order to intervene as early as possible rather than adapt the situation to us? So those are the four challenges. The four challenges I've taken on myself as to how can I implement this learning from this article into my clinical practice. And then they're what I wanted to finish with. So that's it from me. Thank you for listening, and I hope you found some of that interesting. I dare say some of it, I hope in a way, that some of that will introduce some challenge and some food for thought as to how you contextualize TCA and how you understand the survivability of TCA and how we decide whether we do or don't offer intervention. I want to be able to, well, I contextualize it as circulatory arrest rather than cardiac arrest. I think meaningful circulation has stopped. Whether the heart's still beating or not is probably arbitrary. And I want to, my challenge to myself is identify the candidate patient as early as possible and intervene on them, and identify futility and not intervene on them. That's my personal challenge. So thank you for having me. And yeah, I can't wait to hear what you think. So let's talk, and feel free to talk amongst yourselves. It doesn't have to involve me if you don't want it to. So thank you.
Huge thanks, everyone. Wonderful presentation, and it's lovely to get your expertise from your other sides of your work, and I think that's what makes Prehospital so interesting, that it has such crossover with all of the other things that we do in work. And I love any talk with lots of physiology. We're about to publish our similar retrospective study, of course, incredibly smaller than the London guys. So we've done 34 resuscitative thoracotomies in 10 years. So a very small number every year in a system that's seeing more than double the number of patients per year. So, really a tiny percentage, less than 0.05% of our patients are getting thoracotomies. And how to be good at something you're only doing 3 or 4 times a year is very difficult in such a big group. And so we try and keep it simple. The thing that I find interesting that people might not have got if they haven't worked in London or understand the system is that many things have changed with the groups of patients that they're treating over the 20 years that they present. And probably, since it's going back quite a long time, they were for quite a while doing blunt trauma TCA comers. And then eventually moved away from those to more of the penetrating because they weren't getting survivors. They didn't carry blood products at all until relatively recently. So you would expect there would be very few survivors from exsanguination if you're not giving any blood products at all. And they do get a very, very large number of kind of individual chest stabbing, single stab, runaway, which we don't seem to see. And I think that's been quite interesting. So of the 34 patients that we saw in the 10 years, we only saw about sort of 9 patients who had just a single chest stabbing. The rest were either multiple stabbings, and about 9 or 10 of them were shootings, and none of those survived. And then interesting, we almost never see someone with just tamponade. I don't think we've maybe seen 1 out of the 34. All of the others had exsanguination and tamponade, or they had just exsanguination. And we've only had 2 survivors, giving us a 6% survival rate. And both of those were exsanguination, and both of those would not have been necessarily treated by the London colleagues in the past, because they were later, they had multiple stabbings outside the box, as well as a chest stabbing, but we managed to get survival, and that was kind of makes it hard for us to adapt some of the data that's presented here We don't want to throw the baby out with the bathwater. But I think that the big change for us may be that we changed the electrical activity as a sign, because I think that's really hard. It's a nice hard thing. Timings in pre-hospital is just so difficult, isn't it? It's like, how long has the patient been in cardiac arrest, and you just never know. And we learn more and more about that as we do the ECMO trial, where we just can't get a sense of it. There's a great opportunity to ask Halden some questions. So if you could put anything on the WhatsApp group if you're around, or you could unmute yourself. I'm just going to go around the room and see if there's any other questions from the group. Georgina.
In light of the data with tamponade, with blunt trauma being pretty much the same as penetrating trauma, has that changed your practice for approaching blunt trauma TCAs? And are you picking up the probe much earlier, seeing as timing intervention is crucial in these individuals?
Yeah, hi, thanks for that. That's an excellent question, really insightful. And the answer is yes. I think our traditional approach to the blunt trauma TCA is to manage your hypovolemia, oxygenation, and tension pneumothorax, and then do a bit of resus and see what happens, and say, well, it's probably not tamponade. Yeah, I think if there is tamponade, then this data has shown that the time for meaningful intervention is so limited that there isn't time to run a couple of loops and put the tube in and give a bit of volume and see what happens. So I'm trying to scan them very, very early, almost immediately, in order to detect, not exclude, but detect if I can see a tamponade, then the answer is simple. If I can see a tamponade from blunt trauma and they have electrical activity, then I probably would offer them thoracotomy unless there's a clear reason not to. So yeah, I have integrated ultrasound much earlier for those cases. Yeah, thank you. Great question.
Thank you.
Fantastic talk. Agree with so many things you said, and thanks for taking the time to present to us. Truly valuable. You're probably a service that puts in more balloons than anyone in the world currently. And I'm really interested in how you guys would have so much experience with femoral access, as well as using it both for monitoring and putting up REBOA catheters. How are you incorporating REBOA into your either exsanguination management in this patient population, and in light of the publications that have come in the last couple of years?
That's easy. So you're right. I think we've probably done more Zone 1 REBOA than any other pre-hospital service now, but that's because we're offering it to a different group of patients to London. We don't offer REBOA in trauma cases here. We are only offering REBOA as part of the aortic arrest trial, and traumatic cardiac arrest is an exclusion for that trial. It's a feasibility study for the use of aortic occlusion to promote coronary perfusion pressure in medical cardiac arrest only. So yeah, you're dead on. We've done a lot of femoral access and we've put a lot of Zone 1 REBOA in here, but we haven't ever in this service in EAAA used REBOA for a trauma case. We might. The geography for that here is very difficult, particularly with currently available devices. That's changing, but at the moment it's difficult. And the receiving centres in this region are challenged by aortic occlusion. So in our country, London Air Ambulance is the only service using REBOA for aortic occlusion for trauma cases. We've used it in EAAA with manual aortic occlusion for trauma cases, but that probably doesn't contribute to answering your question. So no trauma REBOA here in EAAA, I'm afraid. If you want to learn more about it, the paper that I signposted earlier, the Zone 1 Partial REBOA, published by very similar group of authors to this paper actually, is probably the best available evidence for the use of the technique in the pre-hospital setting at the moment. Does that answer your question? Probably not.
Yeah, absolutely. Yeah, thank you.
No worries. What we have learned a lot about is how do you integrate getting early access to the femoral arteries in these cases, and that's been an interesting learning curve, and I dare say it's one you guys are on with your ECPR program, of how do you adapt your allocated roles and your tasking when you arrive on scene to incorporate early arterial access. That's something that we've learned through doing it for medical cardiac arrest, and we now offer early arterial access to all the patient groups. And in this service, we endeavour to have arterial access prior to ever giving an RSI, and we achieve that about 85% of the time. So we've definitely learned a lot about reliably getting arterial access, and how to incorporate that into like the workflows without extending scene time and without delaying sort of arrival to intubation, for example, for someone with airway or respiratory compromise. So that's probably useful learning too.
Thank you. There's another question in the chat. I'll just read to you. This is from Mark Newcomb, one of our consultants. London HEM's resuscitative thoracotomy success rates have dropped from 18% in 2006 to 10% in 2019 and now 5%. How this has been explained to me in the past is that the mechanisms have changed from the single stab wound to multiple stabs and gunshots, and blunt trauma with vastly increasing complexity of injury as the mechanisms vary over time. Is it reasonable to consider the mechanism of injury as an indicator to proceed more closely?
Yeah, yes, absolutely it is. And that sort of very broad brushstroke of penetrating trauma versus blunt trauma is, as I say, probably arbitrary in some cases. But if you're able to consider the mechanism in more detail, that definitely is valuable insight. Well, what personal things have I got? I've intervened on single stabs and I've intervened on multiple bilateral stabs. The patients who have had multiple, have I had a survivor from multiple bilateral stabs? No, I haven't. Even from in-hospital thoracotomy, I've not had a survivor from multiple bilateral stabs. And I've intervened on gunshot. Gosh, I wish I hadn't really. I intervened on a self-shooting, which was witnessed. So we had a perfect timeline, and he was sort of within criteria, and it was a cardiac box shooting, and that it's just destroyed. Like the heart wasn't even attached to the great vessels anymore, and there was an enormous defect in the LV. So the answer to your question is yes. If you're someone, or if you're part of a team, as I believe we are, or at least should be in pre-hospital critical care, that can analyze the mechanism to the level of detail that you just have in your question. If you're able to analyze it to the level of detail of, is this a single stab? Is it multiple bilateral stab? Is it gunshot? That's much more insightful than just going penetrating trauma, blunt trauma. That's not helpful, but a detailed analysis, I think, definitely helps with regard to candidacy. If someone's got multiple bilateral stabs and they've exsanguinated, I think the game's up. It's probably not controllable. And the same in London, as you found, as Carl mentioned, with your Sydney patient cohort, the survivability from a shooting is much, much lower because of cavitation and injuries to multiple vessels or solid organs causing diffuse hemorrhage.
Thank you. Any others from online who want to unmute and ask a question, or anyone else from the floor? Jenkins, oh, one sec, we'll just pass back to Jenkins.
I'm going to open this up to the group. The question being, is there any sort of positive association for survival from a resuscitative thoracotomy with this, after the resuscitative thoracotomy, the distance to hospital or the time to hospital, from everyone's experience?
This question has been raised predominantly in Northern Europe by our HEMS colleagues in Norway and Scandinavia, who have distances like Australia, where you might be travelling a good hour in the air to get back from where a stabbing was. And we had a stabbing on the weekend, which was a good hour and a 45-minute flight time from a major trauma centre, which is, means they've got a pre-hospital time, significant hour long. And, the question is, will they survive? Even if you get your heart started, that's a long time to be open-chested and trying to keep them resuscitated. And how much blood have you got? We do have access in New South Wales to something called a retrieval transfusion protocol, meaning we can, even before we get to the patient, activate blood transfusions to come from nearby hospitals to the scene or en route for rendezvous, and that maybe gives us a better chance to keep them alive. But if we're arriving at hospital having given them 10 units of red cells and only a few units of plasma, it's probably not ideal. I definitely think it makes a big difference. The longer you are away from major trauma centre, the harder it is to keep them alive. And we've had quite a few patients who survived to hospital admission and died at sort of day 5. And I think the interesting thing from the London guys is they don't seem to have many of those patients. If they manage to get them alive with a beating heart in the trauma centres, they seem to do well. Well, that's the report they give us. Whilst we probably have more of our patients arrive alive in trauma centres and die, and it may just be because it's a longer period of being, low flow state and being chest open and all of the badness occurring, rather than it being a 4-minute drive from East London to the Royal London. You can see the hospital where the stabbing occurred. But it could also be that our trauma centres are not necessarily well set up for after hours arrivals of very sick patients, because all of the surgeons are in their beds and we're an on-call service. So hard to tell.
I'm just trying to find there is a graph in this article. Here it is, that shows the proportion of survivors and whether they died in hospital or not. So I'll just stick that on now, and you can look at it while we talk. Here it comes. Hopefully you can see that. I am with Carl. I think, and I've done an open chest transfer for an hour, and that was another difficult decision, because before we decided to intervene, I thought, is this patient even got candidacy or have they not got candidacy because they're too far from a centre that can cope with this? We were in a town with like a rural hospital in it that had no services that could help us whatsoever. So it was do the procedure now and transfer her for an hour or not, and I decided to intervene. We don't have the retrieval blood protocol that you have. Our geography is not like Australia's, but what we did do is get the controller to activate our sister team, and they drove towards us, and so we had the availability of their blood, and we used it. I think this comes down to whether you get fortunate or not with the pathophysiology, because if you have a tamponade from a single bleeder and you control it, your next challenge is keeping them warm and keeping them asleep. And if you can do that for an hour, then there's no reason why they wouldn't have candidacy. If you've got ongoing hemorrhage from multiple tissue beds and you're trying to keep them warm and keep the calcium topped up and keep ongoing transfusion going during an hour's transfer in the air, that's really damn hard. But that's not something you're going to know prior to the intervention. So my feeling is that being a long way from a centre that can help probably doesn't preclude someone's candidacy, but it makes survival more challenging. And I think, therefore, Cara and I are on a very similar footing with it. I'll stop sharing that graph. There you go.
Any final questions for Hutch? Cool. Well, we'll say a huge thank you. That was a great presentation, and it was a pleasure to hear from you. And good luck with the ATAC course coming up in July. One in July. If you haven't done it, it's an amazing course, really worth doing. A great opportunity to be a candidate again if you're a senior clinician and haven't been in the centre of SIM for a little while. And they make it fun, and they've got an amazing faculty and an incredible facility. So highly recommend doing it. Cool. Thanks very much.
Thanks for having me. Honoured to be speaking to you again in Sydney. It's always lovely to see you on the course if you do choose to come over. A number of your senior team instruct on our course, so you might see some of them there too. So thanks a million for having me. And the job gods have been really kind. I'm not in this for a laugh. I am on a shift, and we haven't been called. So what a great result. And enjoy the rest of your day. Thanks.
Cool, because the council rang to say they want their outfit back.